Michael Blackstone with Lee Talk Radio. And today we have a special guest, Art Vanzee. Art, welcome to the program. Tell us a little about yourself, how long you practice medicine, where you're located, all the good things about Dr. Art Vanzee.
Hey, Michael. Thanks for having me. I appreciate it. Yeah, I'm a primary care general internist. I practice at the St. Charles Clinic, which is one of the Stone Mountain Health Service clinics. And I came there in '76, so this has been about 45 years now.
Wow. Are you originally from Lee County, or?
No, I actually grew up out west. I grew up in Nevada. Went to college in Oregon, medical school in Cleveland, Ohio, Western Reserve. And then I did my internal medicine residency at Vanderbilt. And that's kind of how I got up this way. Is I'd always wanted to practice rural medicine and in an area of need. And in the 70s, Vanderbilt, there was an organization called Vanderbilt Student Health Coalition, which did health fairs in underserved communities in Northeast Tennessee, Southwest Virginia. And it was a very good organization, and they worked with the community trying to help them mobilize and improve their local healthcare situation. So they would have health fairs in the communities in the summer and work with the community groups. And so they had a health fair in 1973 in St. Charles, and in 1974 I mentored the students for a second health fair in St. Charles. And so that was my introduction to the mountains and to St. Charles and a lot of remarkable people in that community, and many of the people that then began to organize and do a lot of grassroots fundraising and basically built a building themselves from the ground up. It later became a federally funded community health center.
That's that's very awesome. So you were back in the day when St. Charles was a pretty thriving community. I guess the coal industry was really thriving back in those days. So I think a lot has changed in the area, has it not?
A lot has changed, and I'm not that old, Michael. And that the heyday was, 20, 30 years earlier. I mean, it was the busiest community in the county. At one time on one shift at Bonnie Blue, which is one of the coal camps there, they had 2,000 miners on one shift. And Saturdays were always described as extraordinarily busy downtown with people shoulder to shoulder. They had hotels, bars, bowling alleys, movie theater. So it was a busy place. It was a dying coal mining town when I came, and we've lost a lot of jobs since that time in the area. So things have, the whole region, but St. Charles has seen harder times since then. But the heyday was much before I came.
You've got a wealth of information, even historically over the past few years and stuff. So let's switch to a subject that kind of hounds all of us here in Lee County. So I'm going to ask you a question just straight out. Do you think there is a drug problem in Lee County?
Mm-hmm. There's been an enormous drug problem in Lee County, for the last 25 years. We were, there always been some prescription drug use in the region to a limited extent, but, beginning with the introduction of OxyContin into the mountains, it was first marketed in '96 and then really began to surface as a major drug of abuse in 1999. And it was just any adults that were around at the time. This was just an enormous tragic problem. So it just became a tsunami of people that became addicted to OxyContin primarily over recreational use of OxyContin. So it was an enormous problem then. What we now call opioid use disorder, what's formerly called the opioid addiction or opioid dependence. And it remains a huge problem to this day. It's been somewhat eclipsed, the last 2 years by the methamphetamines, which are just absolute, it's an absolute drug from hell that's devastating our whole region, East Kentucky, and in many parts of the United States, actually. The other thing and I, the way I look at it is that, my take on it is that this is really, the methamphetamine problem we have has really been related to the original opioid problem, because you had this enormous number of people that developed opioid addiction or opioid use disorder, and it just overwhelmed. The whole region had very little resources at the time in terms of being able to give effective treatment to people with opioid addiction. And what meager resources we had were just overwhelmed. And so that put many people for years, not without treatment, access to treatment. And, many of them just stayed in the substance using world. And what often happens is, people just try the next drug that comes along. And in our case was methamphetamines. And methamphetamines is very addicting. It seems to be ubiquitous in Lee County. It's cheap, readily available, and it's an enormously destructive drug. Not only because it's very addictive, but there's very little to no, at least very, very little effective treatment for it. It's very clear that it does brain damage. It changes people. People can become violent and psychotic on methamphetamines. And,
are you in a? I don't mean to interrupt you. Are you this, because we are doing this interview over the phone? Are you in a changed cell area? You started digitally breaking up there.
No, we're usually in a pretty good area.
Okay.
We usually don't have trouble. Yeah, sorry.
Okay, all right. So it stopped there. So continue on. You were saying, is OxyContin? Do you feel that's still a drug of problem in our region, or has it slowed down with the prescribing of it from federal regulations, or has it gone into this methamphetamine area because of the ability to get it cheaper than maybe the OxyContin type of drug? What's your take on that?
What you saw with the history of the opioid problem going back to 2000, there had been an enormous increase a big increase in prescribing, probably a quadrupling of prescribing from 1999 to 2010, and you had something on the order of a 900% increase in people trying to get into treatment for opioid addiction, and parallel increase in, this is nationally now we're talking, but it's mirrored by what we experienced here, and similar figures for overdose deaths and fractured families, children going into child care, crime on the uptick. And so that was primary prescription opioids, and other opioids were involved, but OxyContin was led the way and was the driver, at least fueled the national opioid crisis. And a lot of that, there were many parties that had some responsibilities. There's certainly, a tragic national epidemic that was, it's not brought to us by a cartel south of the border. This was a tragedy that fell largely at the feet of the pharmaceutical industry and the medical profession.
Right.
So in about 2010, and actually going back to 2000, a group of active citizens in the county had called for, the FDA to recall, they had a petition to recall OxyContin until it could be reformulated to something that would be much less abusable. And that was, of course, never acted on. And then OxyContin stayed in its same formulation until about 2010. In 2010, not too long before its patent was going to expire, Purdue Pharma came out with a more difficult to abuse preparation. And what you saw at that time, nationally and also around here, is the OxyContin prescribing dropped precipitously, and it just kind of dried up in the mountains in terms of availability on the street. But you saw a lot of people then who were opioid dependent going to plain oxycodone, short-acting oxycodone, what they called Roxys or Roxysets, that could be 20 or 30 milligram oxycodone, and then were abused that way, either snorting or injecting. But in a lot of other areas of the country, then people began to use heroin more. Of course, there was heroin use before, but a lot of the people that were opioid addicted then began to use heroin, so there was more and more supply. It was cheaper than the OxyContin, and the less abusable preparation made it difficult for them to use and get the same effect as they did from the older preparation. And so for several years you had excuse me, clear my voice. That kind of second phase of the opioid crisis was, fueled by the heroin around the country, and then, the so-called third phase was and has been the fentanyl problem. So fentanyl, as you know, is very potent opioid. And there's pharmaceutical fentanyl in different preparations, usually used for people that have, terminal illness, terminal cancer, or other terminal illness, just severe pain. But the fentanyl that began inundating the country was this illegally manufactured fentanyl, coming from China or Mexico, it's thought, and it's illegally manufactured in labs. It's hundreds to thousands times more potent than morphine, and so it has been killing enormous amounts of people. They are putting fentanyl in their packaging in fake Xanax tablets, fake Lortabs tablets. Methamphetamines are being laced with fentanyl. Heroin's laced with fentanyl. In Virginia, these are little old figures, but it's 1 or 2 years ago, there was something like 2,300 is not precise, but it's very close. 2,300 opioid overdose deaths in Virginia, like 80% of them were fentanyl. We in Central Appalachia, excuse me, just a minute, I'll clear my throat again. Sorry. In Central Appalachia, where get things sometimes takes a while for things to get here. So, but fentanyl is certainly here. People are dying of fentanyl. It's come in the region last year and a half, and there's just for anybody listening, I mean, there's just nothing safe you can get off the street that might not have the risk of having fentanyl in it, or even pills that look like real pharmaceutical pills that are really masked pills and the fentanyl containing. But go ahead, Michael.
So you in your medical practice and what you do, do you specialize in the treatment of opioid use disorder, or is there other things that you do, obviously as a doctor, but is there a focus on that, and if so, how do you treat this? What's the answer to this? Because there's several types of identifiable types of treatment. I call them types of treatment, but from self-detoxing, counseling, faith-based, medication-assisted, and there may be more. If you can let me know if there is, but of those, what is your feelings about those, and how do you approach this?
Yeah, but just to give a little more background how I got involved in this. So, I was here, about 22, 23 years or so before the drug problem came. I never really had any, particular training in addiction medicine, and really didn't have any particular interest in it, and so I was fairly ignorant about it. And then, in 1999, 2000, when we started having this just enormous number of people getting addicted to oxycodone, these were parents that were telling me about their children that had become oxycodone addicted, or grandparents telling me, and then a number of young people coming to see me for trying to get some help, and really I didn't have any training, didn't have any skills to offer them. But it was very compelling to me because so many of these young people were, people they had known since childhood, knew their families, sometimes, involved in several generations of their families. And so I tried to get some skills, tried to get some education skills and learn to do what I could to help along the way. So that took me to the organization called American Society of Addiction Medicine, which is a society of physicians in the country that really specialize in addiction medicine. There's about 6,000 of them. It's a great organization, a lot of very good folks there. And so that organization was a mentor for me, and many people in that organization were. So I started getting some training and skills. Over the next few years, I became board certified in addiction medicine. And what was hopeful at the beginning of what we were seeing in 2000 in terms of treatment was that there was a drug called Buprenorphine. That's a generic name, Buprenorphine, and people know it more in the press and, on the street is Suboxone, but the generic is Buprenorphine. But this promised in all the studies to be an effective treatment for people. And just to give a little more understanding about how that works, I don't know how we're doing for time here, Michael.
Oh, we're good. We're good.
Okay.
We got no time constraints. We're good.
Okay, so tell me to shut up around Wednesday morning then, okay? Now we'll go on here, but no, just to give you just a little understanding about, what opioid addiction is, what does it mean. And so people can take opioids, for a fair period of time, and opioids act in the body by, activating receptors. We all have different receptors in our brain for all kinds of different things, and there's opioid receptors there. And the most important one for this discussion is so-called mu receptor. So what happens? So if you have an opioid that sits on the mu receptor, it activates all those processes so that can give you, pain relief and other things that opioids can bring. And at some point, for some people, those receptors really change, and when they change, when that receptor isn't occupied, then people can have two things. They can have, even once they become addicted, then they can have two things. They can have terrible cravings and terrible withdrawal. And the withdrawal is like the worst flu, you ever had. And then you have this compulsion and craving to use. So, people can become addicted to opioids just taking them orally, just as directed. And that's quite possible. We see it more commonly when when the route of administration is altered, whether it's snorting or injecting. You have a rapid delivery to the brain, and that kind of rapidity of the brain exposure to the opioids makes it much more likely for people to become addicted. So once somebody's addicted to opioids, then, like I said, when they're not there, you just feel miserable, and you do have this important craving, and I mean, this very difficult craving and compulsion, and it's it's those two things that really drive people to keep using. I mean, they don't get up in the morning and every day for the last year and go out to get high. They just want, or so many of them just want to be able to feel normal and be able to get off the couch and take care of the kids and go to work. And you can't do that with empty receptors, basically. And so they use, enough to. I mean, I have patients who come to me and tell me they haven't been high for a year, but they're using just so they can feel normal enough or half normal enough to be able to function and do what they need to do, social, personal, family-wise, work-wise. And so those are the things that drive people on once they're in opioid addiction, and that compulsion and that craving and of wanting to avoid the terrible withdrawal is what leads, to all the behaviors which cause so many problems for people in their families, whether it's lying, stealing, not being honest, all those things that fracture relationships. And that's going to happen. That's going to happen with almost anybody that gets, opioid addicted. They can be the person working in the convenience store. It can be a teacher. It can be a minister. It can be the anesthesiologist diverting fentanyl in the operating room. That's the nature of the disease. It's a terrible disease. These are not terrible people.
Let me ask you a question. So you're saying, if I'm understanding this right, a person who takes the opioids, this actually is chemically changing your brain receptors, and thus causing these addictive problems that go on. So are you saying, how do you treat this? Are you saying that the use of the pharmaceutical or buprenorphine is the only way to counterbalance that, or are you saying that is this something that cannot be self-detoxed or more counseled, or is it all of the above? How does it get free of this situation?
Okay. Yeah, I appreciate the question, and I'm not trying to dodge it. I want to come back to it, but I just realized that as the conversation it is may leave some people, if they're listening, really worried about there are a lot of people that take and have to take chronic opioids for terrible chronic pain. And I take care of a lot of people with terrible chronic pain. And some of those are on opioids, and it does improve their quality of life and so on. But there's a real difference between, taking opioids for chronic pain, and that doesn't mean that you're addicted. If you were on opioids for a long period of time, even for 3 or 4 weeks, and were to suddenly come off, there'd be some physical withdrawal that everybody would have. But that does not mean that you're addicted. So I don't want people to think that, because their doc or their primary care provider is prescribing them opioids, and they had a little withdrawal, they're addicted, and there's not. There's a real distinction there. And we probably don't need to belabor it anymore. I just don't want people to, feel that they're addicts because they're taking chronic opioids for terrible pain.
I think a lot of the the general public's view. I think you have different areas of society, and I think citizens in the county, whether they're basically because of their faith, maybe because of their jobs, because for their social levels, so on and so forth. They look at it and they look at drug addiction as if that is the you come the scum of the earth, or you're a criminal, which we both know that that's not the case. There is I could have been in an auto accident, hurt myself, been prescribed pain medication by my doctor, and now I'm hooked on this stuff. So there are good people that are, trying to get unhooked. They're not just all criminals. So I think society at large looks at it as drug addictions, and then when you bring in to different treatments, and we talk about, so we'll just call it Suboxone because people recognize that name more. Then they look at that as, okay, that's another drug. Is the best and most effective way of taking care of these problems, prescribing one drug that is also an opioid, and prescribing that on top of medication, or is there better ways of counseling? And if you are taking that Suboxone, are you considered a drug addict or a bottom line criminal or something like that? So there's stigmas that go along with it. How do you address that?
Just to address, I think your very good point about stigma and attitudes, and there's just overwhelming evidence that this is a disease. This is a brain disease. If you get any kind of addiction problems, but especially opioid use disorder, and the prevalent view in lay society is that people just have to, quote, straighten up, unquote, or start behaving and just start acting right. And in other words, they make this kind of a moral failing on the part of the individual afflicted with this. And it's a situation where it's a bad disease. They need to get treatment. They need to get better. It's not just something that can be addressed by just, quote, straightening up. Anyway, there are a number of different treatments that have been used for opioid addiction, stemming back to many years that we've dealt with heroin in the country. But there's just an abundance of evidence that what they call medication-assisted treatment, and this is either with methadone or with buprenorphine, Suboxone, is clearly the most effective treatment for people. And I began involved with and treating people with opioid use disorder a couple of years before buprenorphine Suboxone became available, and that was treating them outpatient-wise, trying to have them involved in meetings, counseling. This whole community group had worked hard and put together New Beginnings, Southwest Virginia Drive, where people stayed for 3 months at a time, and so on. So I had some experience in the addiction treatment field before buprenorphine in treating opioid use disorder, and uniformly the things were not very effective. I mean, it is such enormous, powerful addiction, the buprenorphine. So I've been using buprenorphine now. It came out in January 2003. I started in February 2003. So I've been using it, almost 20 years. And by and large, it's a very effective treatment. I've in 45 years of internal medicine in a small rural area, you get to do a lot of things that are pretty neat, pretty meaningful, and you get to see the results of. But I've been using buprenorphine treatment for people with opioid use disorder has been as meaningful as anything I've done, and because people can, it really can, in a relatively short time, stop using, and then begin to really be able to get their lives back together. Whether that's really being able to get back to work, or being a responsible parent, or partner in their relationship, and so really, you can really see, it's healing of relationships, healing of how people feel about themselves, it's very gratifying to see. And does it work all the time? Of course it doesn't work all the time. We don't have anything that works all the time. But it works often. And, I have people that, and just going back to predate that. So what happens with the buprenorphine, it occupies the receptor, which, as we said before, when it's not occupied, when it's an open receptor, you have to have a craving, to have a withdrawal, and then going about try to remedy that. With buprenorphine, if the dose is right, you can feel normal. You don't have cravings. You don't have withdrawal, and then you can go about, trying to function normally. So if somebody's very intent on quitting illicit use, illicit drug use, this gives them a big opportunity. And I have patients that, have been, their lives were just, in shambles basically, and their personal life and family life. And, for 15 years, they've been able to be good spouses, good parents, working hard, productive citizens. Many of those people will tell you Suboxone saved their lives. And that's not anything special or magic I did. I was just a conduit for making treatment available to people. Now there are there are other things to who will come back and address, I guess, whether it's changing one drug for another. I might as well talk about that now. So, this is always time brought up. The people saying, well, I don't want them to get addicted to get addicted to Suboxone, and it's just changing one drug for another. And I think that's, such a incomplete view of things and such a incomplete understanding of the situation. I mean, on the one hand, if you're using OxyContin, you are usually, feel bad. I mean, maybe alternate between being high and being in withdrawal. You can't function very well. You can't be a good family member or parent or spouse. You're probably not going to be able to function very well in work, and you're going to feel lousy much of the time when you're in withdrawal and don't have. And then you're going to do like almost anybody else with opioid addiction does. You will do what it takes to get money to be able to get your drug of choice. And you contrast, and then with that continued use, what you see also is these higher risks to getting hepatitis C or HIV or other major problems with your health, medical complications of your opioid addiction. And then if you're using buprenorphine, Suboxone, it is an opioid. If you just suddenly stopped, you were on Suboxone, buprenorphine for months and just suddenly stopped it, you'd have very typical opioid withdrawal. You would feel terrible. You'd have sweats, chills, ache all over, diarrhea, and just feel like being in the bed for a long time. So, no, you have typical opioid withdrawal, but the big contrast is that, if your dose is right, you're going to be able to feel pretty normal. You're going to be able to function with your family. You'll be able to behave legally in most aspects of your life. And your risk for being incarcerated, your risk for catching HIV, contracting HIV, hepatitis C, or other medical complications of continued illicit drug use is so much reduced, So that, in my mind, is hardly something that's equivalent when you look at those two things. I got a lot of patients who've been on Suboxone a long time now, and when you talk with them about trying to come off, many of them, and most of them, don't want to come off because they know what shambles their life was in when they were actively using, and they want to do everything they can to never let that happen again. So maintenance treatment for them is certainly the best option. I think counseling certainly has a role in helping people stay in recovery, establish recovery, stay in recovery, and I think any use of substance use counselors that can be available is important. I think I'm a big supporter of 12-step meetings. I'm a big supporter of the 12-step program. As you know, it's not a religious program in the sense of being tied to one particular faith or anything, but it's a very spiritual program. I think that the kind of spiritual changes that come out of being in a 12-step program, really understanding a 12-step program, being involved in it, having a sponsor, and growing in that 12-step program is, they're pretty profound changes that they can make in people. So I'm all supportive of that.
Are there those kind of programs in Lee County?
We had more before the pandemic, and that really hurt all over the country. That hurt 12-step programs, and we have some. We've got some group meetings, like Lee County Counseling has some group meetings that are not necessarily 12-step based, but are still important kind of meetings. They're faith-based. We do have, they call it the 12-step. Yes, there are a few 12-step programs that are still functioning in the county. We need much more. We need much more. And then there are faith-based programs and opportunities, for people. And I think that, that doesn't fit for everybody, but it's certainly important for people, and it certainly helps a lot of people. But from my own point of view, that should not be the sole treatment for people that have opioid use disorder, because the chance for relapse, if somebody has a long-standing opioid use disorder, their best chances for being able to stay free of illicit opioid use and to stay in recovery for a long time is with the use of medications. And that's not to minimize the importance of faith-based programs. I think they can help be effective, but I don't think they should ever replace. I don't think they should ever be the sole treatment, SOLE treatment for people with opioid addiction.
What you're saying is you are very proactive or pro-supportive of all of the programs. You just feel that because of the medical or science end of the addiction to opioids, that in many cases the only way of truly being able to effectively treat that is with a medication or something that can help do that. Is that basically what you're saying?
That's correct, and there's an abundance of science to show that. So, yes, it basically. Do
you think that Suboxone? Because I've talked to law enforcement all over the state, and their opinion is that Suboxone is becoming the number one, or has become the number one drug currency of choice out there, where people are buying, trading Suboxone for the their other harder drugs, or heroin, phenols, and even meth and stuff like this. So, what's your thoughts on that? Is Suboxone an easy drug to abuse? Are we looking at it from the standpoint of it's just, if somebody wants to abuse, they can abuse anything? Is it that mentality, or is this a type of a drug that is just as addictive as the base opioid, and we're just kicking that can further down the road, I guess?
Okay.
What's your opinion?
My opinion is there is a lot of Suboxone on the street. Suboxone is abusable. Um, most of the time it's not abused, but it certainly is abusable. Suboxone can be snorted. It can be injected. Um, there's a very rare person that will become their drug of choice, but that's rare and uncommon. Um, and there's a lot of Suboxone on the street, in part because there's a lot of people that have opioid addiction, and they are not in formal, they're not in formal legal treatment, and they take Suboxone to keep from being sick. Sometimes it's between, that they can't find maybe what they wanted, which is, whether it's Percocet, Lortab, or something else, or Panids or something, and they're sick and in withdrawal, and they take Suboxone because they know that'll help them with withdrawal, keep them from being sick. So there's a street demand for that. I'm sure that people sell Suboxone, for to people and get other things that they want. But what I see I see people that like were in treatment years ago with me, and they kind of tapered off, dropped out, and then a few years later they come back to see me, and they basically been buying Suboxone off the street for the last 6 or 8 months, haven't used anything else, but they knew they were going to relapse, and they just started getting Suboxone so that they would not relapse to illicit use. And there's a whole lot of difference between, using Suboxone, even though it's not legal, off the street, so you don't use, so you don't use other other illicit opioids, and particularly at a time when there's so much fentanyl on the street. So, if you can keep people from, being out there looking for opioids that might have fentanyl in it, there's some harm reduction. So, what law enforcement doesn't see, and it's kind of like the 6 blind men checking out the elephant. One feels like the elephant is a tree, and another person feels it's a snake, and so on, depending on what part of the complex picture you're looking at. And the analogy here is that, law enforcement does, and the judicial system in general has a negative view of Suboxone because they see it so much. They see a very different side of it than I do. I mean, I'm aware of their side, but they see the side where they stop a car. It's got, it's got marijuana, it's got syringes, it's got oxycodone, it's maybe some fentanyl, a whole clan, and they got some Suboxone. They're selling Suboxone too, or Suboxone being smuggled into jails, or all the kind of stuff that they see with Suboxone. What they don't see is, what I see. I only know their part from what I read in the, I obviously don't go with them, but from what I read in the papers on their side. What they don't see, they don't see somebody who's, was addicted to OxyContin and for 2 or 3 years was injecting OxyContin, their family was, barely getting by. The children were neglected. Person barely could go work, and then this person gets, a chance for treatment, and then for the next 15 years, has done great. You know, they've had no illicit drug use. They've been in good recovery. They've been a good father, a good husband. They don't see those kind of miracles of recovery. And so, you know, to me, there's no comparison between, you know, having Suboxone on the street versus having fentanyl or heroin on the street.
So I think I agree with you, and I think overall, you know, my opinion of a lot of this, I've never done any kind of drugs, and I don't have addiction, so I can't completely relate. I can relate from a common sense standpoint, and you know, just as a person walking the streets, just like everybody else, and walking through life. I think that whatever way that you as an individual can get the best response, the best healing, and the best care that your body responds to, and then you can continue being a productive member of society and, you know, raise and take care of your families and take care of your business, I think becomes the appropriate choice. And whether that be a faith-based or counseling or a medically assisted type of a treatment, I think that becomes what's right for you. I think society overall needs to stop maybe stereotyping all of this and paint it all with the same brush. And I even myself have been, you know, guilty of that. When I first started looking at this problem and doing some fairly extensive investigative reporting on this whole crisis and Suboxone clinics, you know, it looked like a wave of actual street terror coming in from the drug side of things. But then, you know, as you look at it more in depth, I had to remove myself and my personal opinion out of it and say, what is the best way for people on the streets of Lee County? And what I've come up with is that I think that in our county there's not enough treatments of all kinds, mental health, abusive situations where women and children are abused. There's, you know, as far as, you know, inpatient recovery centers, things like that. I mean, we just don't have any.
Right.
And I think it's something that we need more of, and we need to really support those that you can only help those who want to help themselves. And if a person has an addiction problem and the first thing that they've done is said, look, I have a problem and I need help, and they're trying to get help, whatever direction they gravitate towards, it is really doing that for them, being these different things that we've discussed, you know, medicated assisted programs, faith-based counseling, whatever works for them. And I say they need as much of it as, you know, we can all help them get, and so on. Are there going to be people who abuse stuff? There's people who abuse eating ice cream. You know, I mean, if they want to abuse something, they're going to figure out a way to do that. But like you're saying, the whole wave of this drug issue has changed from the Oxycontin days. You know, I did an interview with Sheriff Gary Parsons, and he was an investigator for the sheriff's department back when Oxycontin was really, you know, at its prime. And he said that the things they had to deal with on the law enforcement side of that were bad. He said, but nowadays, he said with meth and some of these newer misused drugs and things, it is 1,000 times worse than they ever saw in that era. And I guess the the treatment of opioids, I think a lot of people are confused about this, but the treatment of opioids or opioid addiction with maybe the use of a Suboxone that does not work in the treatment of meth and methamphetamine. Am I correct in that?
Yeah, that's right. It doesn't have any effect. That's right. But just to elaborate on your emphasis on treatment, yes, we need. I mean, it's been a huge problem from the beginning of the OxyContin problem. From my point of view, that we had even up to this day so few treatment resources. So, especially the early years, we had, the emphasis was on incarceration. And there wasn't really provision of treatment. East Kentucky, although they had a terrible problem then and still have a terrible problem, they really did concentrate more on provision of treatment. So they built residential treatment centers. There's one over in Harlan. It's a 100-bed treatment center for women. They can stay long-term, 1 year, 2 years. And so many people can do well with long-term residential treatment. We need residential treatment. We need expansion of drug courts. So very glad to have the current drug court going. We, could have used it well 20 years ago. But it's been going, expanded. My understanding is doing well. But any kind of treatment that you could provide. Now, I understand that there is a developing clinic in Lee County that's going to be providing Suboxone treatment, and I don't know anything about that particular organization and what it's like, but so I can't endorse that particular organization, but I can certainly endorse treatment. We need treatment available to people. I mean, if somebody who's battling their opioid addiction someday decides that they want to try to get help and they want to they make that desperate, difficult to make call. You don't want to say, well, here's an appointment in 4 weeks, I mean, you could be dead or in jail in 4 weeks, You want to be able to call and, get in within a day or two, the treatment. And our current treatment resources aren't that, are limited so that we can't do that. But yes, we ought to, as one of my colleagues said, they ought to be able to get into treatment just as easy as they can reach their drug dealer, same day.
That's a great analogy. That's
because there's a lot of people, yes, they get so frustrated by a system that is not, that is very difficult to get into treatment. And so, I think the importance of any organization coming in any county, if they're going to provide Suboxone treatment, I would hope that they take, for many years, 95% of the clinics in 100 miles of us were cash-only clinics. Didn't take Medicare to Medicaid commercial insurance, and it charged $100 a week. And so that was a huge obstacle for people. And that's changed some in the last 5 years. There are more clinics that take Medicaid and insurance. So I would just hope that anyone coming in, yes, that it's going to be very accessible, available to people that'll take Medicaid, commercial insurance, and otherwise try to work well with people that don't have those kind of insurance resources. But we need more treatment.
I'm going to ask you one last question. And I really appreciate your wealth of information and knowledge in this whole subject, and I think that our listeners are going to appreciate this, because one of the biggest things is when you see, like you've already mentioned, that there is a new clinic coming in, and it's been on the front page of the paper, and there's many controversies and stuff, and I think that you kind of educate the public. You got to be educated in what you're talking about. Otherwise, it just looks like a bunch of drug mess. And I think that the citizens of our community will appreciate your information and take on this, so that we can become more maybe open-minded to the various treatments. I mean, let's face it. We're talking about self-detox, faith-based, or medicated assisted. And then if we're talking about medicated assisted treatments, you know, buprenorphine and I mean, what else is there? That's kind of it's isolated to a specific thing. And the federal government has approved it. It's, you know, we've got the ARTS program. The state has made, you know, mandates and approvals for this. So it is something that's becoming more prevalent. So last question, what do you think the citizens or county government can do to be more supportive in this whole area?
Gosh, you know, anything that they can do to support treatment for people, and that could include supporting residential treatment initiatives. That can include supporting clinics that offer addiction treatment services. If there's any way of supporting 12-step groups, you know, if people have interest in, you know, there's some people that want to go to 12-step groups, have no transportation. Maybe church-related people can be involved in that level of support. We really need to look at all kinds of ways that employers and organizations can make jobs for people in early recovery. You know, people have such trouble getting jobs, and so if there are programs that specifically will help people in recovery. Mountain Empire has a very good program now. I forget the name of it, where they're training people, specifically people in recovery, where they're training them for jobs and vocational things. You know, we need tons of that stuff. You know, anything that's going to take provide treatment. We need treatment in jails. My goodness, people go to jail and or prison. There's some prisons that have good treatment programs, but you know, you need to have treatment programs there. There's so many. There's such a high rate of overdose deaths in people leaving prison, leaving incarceration and coming out into the world, you know, relatively short time after they get out. And part of it is they haven't had treatment things while they're in there. Part of it is that the people are unaware that they lose their tolerance to opioids, and they come out and they do the same thing that they had before. They lost their tolerance, and so the same amount that they used before without difficulty, it gives them a fatal overdose. But they leave prison without any linkage to treatment. You know, there's so many things that can be done to prepare people on leaving incarceration about what are treatment sources available. You know, what kind of linkages can you have to anything that's going to you know, help them with locate treatment, or you know, help them you know, from any kind of social support point of view. You know, I'm a big supporter of there was a long period of time where some drug courts wouldn't allow a Suboxone treatment in the drug court. And, you know, I thought that was so short-sighted and so lacking of understanding what the evidence was. That, I mean, to take somebody with a long-standing opioid use disorder and expect, even with the resources of drug court, expect that they're going to be able to not lapse or relapse without medication-assisted treatment is, is expecting too much. That's the nature of the disease is it's a relapsing disease. You give them the best possible chance. And this is not somebody who's, been opioid, dependent for 3 months before they get incarcerated. I mean, they may need treatment and never have to be on long-term buprenorphine treatment. But for somebody who for years has been opioid dependent and their brain chemistry has changed and they've got a lifelong disease and it's going to take lifelong work to keep them sober.
Just off the top of your head, somebody said how many people you think are in Lee County proper that have an opioid addiction? What would you say? There's hundreds, thousands?
I have no idea, but it's much more likely to be in the thousands than hundreds. I mean, when in the height of the OxyContin problem, in our region we have many tens of thousands. So I have no idea, but it's certainly not in the hundreds. It's in the thousands.
Yeah.
Yeah. Just rough guess. No data to go by.
Right. Well, Dr. Vanzee, it was you had extremely valuable information. Thank you for being on the show. I'd like to be able to come back and bring you on some more down the road. And you have any last thing you'd like to say, or do we call it?
Well, my thanks to you, Michael, for doing this, because it's a huge issue. It needs community forum, community discussion. And the more information that's out there, the better. So I thank you for your initiative and your role on this.
Well, I appreciate that, and we will talk again soon. We'll call this a wrap. This has been Lee Talk Radio interviewing Dr. Art Vanzee. Thank you for your time.
Thanks, Michael. Okay, bye-bye.
Bye-bye.